Hi, this is Brian Kim. I'm going to share with you case number 20 in the best way to do cataract surgery series. This is a soft lens. Some people have difficulty disassembling the soft lens. And so this is because they try to use vacuum and ultrasonic energy to prolapse the lens out of the bag. The lens falls apart or it crumbles, and then you end up with a bowl. And it's very difficult and challenging and actually more risky to try to take out the pieces because you're trying to use the phaco to grab the pieces out of the bag. Now, I do want to share that this is not anyone's fault. This is the way traditional cataract surgery has been taught, doing sculpting maneuvers, cracking, etc. And so when you sculpt and crack, that causes the lens pieces to crumble and fall apart. And then you're supposed to pull the pieces out with a phaco tip. And this is kind of a backward way to take out a soft lens. And so I will show you how taking out a soft lens should not be difficult. Actually, using mechanical fracturing techniques, one of the easiest lenses to take out, and struggling with the soft lens will be a thing of the past using these techniques. So I use a corneal mark to help me center and size my rhexis. I make my paracenteses incisions superiorly and inferiorly. You can see I'm using a metal blade this time, but it doesn't really matter what kind of blade. The technique is maintain a flat configuration with the blade parallel to the iris plane. I'm injecting lidocaine and epinephrine and then dispersive viscoelastic. With the cannula in the eye, I do my triplanar corneal incision. I make a vertical groove, go into the groove, and then tunnel through the cornea and then dive down, and that's my triplanar corneal incision. I begin my capsulorhexis. I puncture using the forceps, pull down and sweep a little bit to the right to create a little bit of a C-shaped flap. I'm trying to grab the very edge of the flap, and then I begin to pull. It's very important to make sure that you have good control of the flap, otherwise it can start to radialize. I'm going around following my corneal mark, which will help me center and size my rhexis. You can see I'm just very carefully going around, intermittently grabbing and re-grabbing, making sure I don't lose any viscoelastic during these maneuvers. I then begin my capsular fornix hydrodissection technique. I place the cannula out to the equator, flat underneath the anterior capsulorhexis edge. I rotate the tip 90 degrees, pointing downward, and then you can see a very nice, easily flowing fluid wave. I decompress to the left side, and then I begin to spin the lens to the right side. And in this case, I was able to spin the lens very easily. After irrigating the cornea, I use my chopper to lift the main incision, and then I place the phaco tip in without irrigation to minimize Descemet's trauma. I then begin my chop technique. I remove the surface epinuclear material. I place the chopper out to the equator. I'm able to follow where the epinuclear step-off is, where I remove the epinuclear material. I'm able to glide past the epinuclear material, sliding out, making sure I'm within the bag. I place the chopper out to the equator. I turn the phaco tip more vertically, and then I have both instruments meet to the center, crushing the girth of the lens material, and this is the double chop maneuver. I'm able to bisect the lens completely in half. I place the chopper out to the contralateral equator, pull the chopper centrally towards the phaco tip, and then I'm able to crush the right heminucleus. I begin to successively crush the lens pieces, again using mechanical fracturing forces, crushing the lens piece, again placing the chopper out to the equator whenever I need to, and then crushing the lens material between the chopper and the phaco tip. I'm using intermittent bursts of vacuum, and in this case I'm not really using much ultrasonic energy because this lens is a soft lens. Anytime you get into trouble, the key is not to grab the lens pieces with the phaco tip. This is the first point and the mistake that most surgeons make and that I see, and that's really going to be where you begin to struggle. With the chopper, it's very safe. As long as you know where and how to place the chopper, this is a very safe maneuver to prolapse the lens pieces out of the bag. Once the lens is completely removed, I push BSS to stabilize the anterior chamber. I pull out with the phaco tip, and then I go in with the INA handpiece, inflating the eye and then pulling the cannula out. I'm able to go circumferentially using my aspiration and vacuum to remove the cortical material. In this case, the cortex was not very adherent. I was able to remove that fairly easily. I'm polishing underneath the anterior capsule using the polish mode, making sure I remove as many lens epithelial cells as possible, and then I begin to polish the posterior capsular surface as well. You may be surprised by how much actual cortical material you'll find when you polish the posterior capsular surface. Using this polymer tip and the polish mode makes this a very safe maneuver. I'm able to then push BSS into the subincisional capsular fornix to remove any potential cortical material. In this case, there was not much cortical material in this space. And then I'm injecting cohesive viscoelastic and then placing my capsular sweep through the other incision simultaneously. And I'm sweeping underneath the left side of the anterior capsular surface. You can see there's some lens material that's liberated doing this maneuver. And then I switch to the right side and I'm polishing underneath the right side, and you can see a similar result. After I'm done, I inject my single piece acrylic intraocular lens using the injector into the capsular bag, and then I go in with the INA handpiece, and I'm able to rotate the lens 90 degrees clockwise and go underneath the lens. By doing this technique, I ensure that both haptics are within the bag, because as I tilt the lens, the optic goes into the capsular fornix, and when it tilts and shifts, I know that both haptics must be in the bag. The lens would not slide over into the capsular fornix. I remove the viscoelastic from underneath the lens and in the anterior chamber, and then I hydrate my incisions. So again, this is a case of a soft lens. For some reason, again, this is one of the most difficult cases that surgeons encounter. It's not because the lens is dense, it's because when they try to use the phaco to pull the lens out, and if the lens is stuck to the bag or if it's very soft, the lens just cheese wires and falls apart and breaks apart. It's difficult to crack, it's difficult to sculpt, and it's difficult to separate the lens using the phaco. By using mechanical fracturing forces, these become one of the easiest cases. You can see there's no CDE virtually used. You can mechanically fracture the lens pieces very easily between the chopper and the phaco tip. Using the chopper very confidently, you can maneuver in the capsular fornix space. And this is, again, a very safe maneuver as long as you know what you're doing and you're able to prolapse the lens pieces without any regard or any worry that you're not going to be able to take the lens pieces out of the bag. So again, I hope this was helpful to you. Please like and subscribe, and I thank you for your attention.